I will cover with you today fracture repair. These are two sets of bone with a fracture here. One view is another view, and there is a healing here. You can see that there is a high density here and even callus formation and leading to healing. I will not go into for further details. These are the specific learning objectives of the fracture. I will cover some little bit of details. Healing of bone is of two types. One of them is called by primary healing or by primary intention. This is the type when there is no inflammation, as I will describe now. It's not an inflammation. It's a inflammatory response. It is not a bacterial. It is not. It doesn't cause itis. And there is a cuts of bone, like in surgery. You cut intentionally the bone. You make a wedge, or you make a hole in the bone, and then you put both ends together, and they heal. They heal fast, but there is no inflammatory phase, and the bone ends grow into each other directly, right? And there are a few other differences also. And the secondary healing of bone, which is healing by secondary intention, this is the one that I will describe now when there is an inflammatory response. We'll come back at the end of this unit when we talk about wound healing. There is also primary intention and secondary intention. That means the wound, healing of a wound with no infection, like surgical wound, and healing of an infected wound. There is also stress fracture. This is a special category. I will touch it very briefly. And there are a few other items that is also worth discussing. Fracture, as you know, is a discontinuity of a cortical bone. Cortical, not the woven bone, not any other types of bone, only the cortical ones. The causes is a trauma, this is the commonest one, but there are pathological fracture if there is a disease of the bone itself. And there is also this stress fracture, which I said I will cover briefly. The complication of fracture, these are the immediate complication. There is impairment of movement and function, soft tissue and muscle necrosis, bone and cartilage necrosis if the cartilage is involved, or if the bone is fractured extensively. Hemorrhage, which can lead to hypovolemic shock, especially if the fracture is in a concealed area like the head of femur or the vertebrae or ribs. Tear of tendon and ligaments, tears of also and damage of nerves and fat and bone marrow embolism. Chunk of bone, the medullary cavity of bone is full of fat and fatty marrow. Chunks of this can escape into the venous system, travel elsewhere, and block pulmonary arteries or any other organ. The complications of the late complication described in your books, these are the malunion and pseudoarthrosis, etc. These are complications of the healing. They are not complication of the fracture itself, because in primary intention and healing by primary intention, there is no late complication. It's only immediate ones. But I will mention them also in a minute. Before I go into fracture repair, because there are cells involved here. Cells capable of producing bone. We're talking about bone, so what are the cells that produces the bone? There is the so-called osteoprogenitor cells. Osteoprogenitor or pluripotential, it's the same. Or even stem cells. These are cells capable of differentiating, it is maturing according to the need of the body into several lines. One line is to make osteoblast. The osteoblast can synthesize osteoid and woven bone. If these finish their differentiation and mature, they become osteocyte. These are permanent, they do not divide. Only the osteoblasts are capable of division. Same with the chondroblast. If with a fracture, with healing of a fracture, you find cartilage. If you don't see it radiologically, but you see it microscopically, there is a cartilage formed by osteoblasts. This is these chondroblasts. These chondroblasts came from the osteoprogenitor cells, which is the stem cells. And when these mature, they are called chondrocytes. These are well differentiated. They do not divide. And you have also fibroblasts commonly found in the bone. So these are the three types. They all come from osteoprogenitor cells. The osteoprogenitor cells, you find it in all osseous parts. You find it in the periosteum. The periosteum is very rich in fact, osteoprogenitor cells. Medullary cavity, bone marrow, surrounding mesenchymal tissue. You find them. So these are the three main types. But there are, from your reading, you find that there is another one which is called osteoclast. Where does it come from? سمعت عن هني شيء؟ Yes, they come from the monocyte. These are monocytes. They were in the blood vessels, and when they leave the blood vessels, we change their name. We call them macrophages, we call them Kupffer cell, we call them astrocyte, we call them so many names depending on the organ. So in the bone, we call them osteoclasts. These cells are not capable of division. They are capable of fusion. They unite with each other. They become very powerful clasts. They remove all the debris, all the dead material created by the fracture, etc. So these are the four main types of cells that you find in bone in general, including fracture. All right, there are three phases. In some books there are even 4 or 5 phases. In some other books there is one, because it's quite continuous process from the fracture until the healing. If you look at it, examine the site of the fracture periodically, if you take sections, microscopic section, you find that there is a mixture of these phases. So it is very difficult to put a line, say this is where inflammatory stop, or this is where reparative stop. It's quite continuous, but for descriptive purposes, it will be made into 3. The appearance of each of these varies from one patient to the other, from one bone to the other, depending on lots of modifying factors, which I have listed here, and I will leave it for you to read. Immediately after a fracture, there is a hemorrhage. So what is the status of that site, of the site of hemorrhage, of that fracture? There is hemorrhage and clot formation. This hemorrhage came from blood vessels in the bone itself, in the periosteum. The periosteum is very rich in vascular supply, from the soft tissue, from ruptured veins and arteries. So it's a big amount of blood and blood clot. Also, there is a standard inflammatory exudate. Remember, near in Unit 1 or Unit 2 when you studied inflammation, and we said that one of the causes of inflammation is not necessarily an organism. Trauma by itself can cause inflammation. So this is one example. This standard inflammation is not composed not only of cells but also fluid, plasma fluid. The clot contains fibrin protein. The fibrin makes a mesh, shabaka. It makes a shabaka on the blood clot. On this mesh or this shabaka, blood vessels can proliferate and the exudate can spread. Cells, osteoprogenitor cells, can also spread on this mesh in order to help the healing. Also caused by inflammation, by the trauma, is the bone death. The bone becomes dead. The fragments, especially at the end of the bone, are dead now. There are no proper Haversian system. The osteocytes are dead in their lacunae. Hafidha, if you have read this histology of bone. These are all bone necrosis, need to be removed. There is also disruption of the blood supply and soft tissue injury. So this is the status of the bone created after the fracture. All of this need to be rectified. All of this need to be removed. So the body started to remove it and replace it by fibrous tissue. Fibrous tissue, it comes from the fibroblast, one of the osteoprogenitor cells. Mind you, the blood vessels, when they proliferate, they bring not only life blood to it, but around the capillary blood vessels there are cells called myoepithelial cells. They are a mixture between, their function is a mixture between being an epithelial and being a myo. When they mature, they contract, but they are fibroblasts. Anyway, so immediately after the clot formation, that clot needs to be organized, i.e. need to be removed. So the blood vessels invade, they remove all the debris, the cells, inflammatory cells there, macrophages start removing all the debris, and bone started to form from the osteoprogenitor cells and from the remnant of the bone itself, a live remnant, like in the periosteum. Periosteum is a very peculiar tissue. If you irritate that periosteum, it immediately makes bone. This irritation may not necessarily be a disease. If you hit the periosteum repeatedly because of various reasons, it forms bone, woven bone, reactive bone, to protect itself. So it's natural process. So there are trabeculae of woven bone, some have bone scar, that you started to appear at the site of the fracture. If there is a cartilage, it can also be removed by endochondral ossification. It becomes ossified. So the end here is to try and remove it, replace it, remove all the clot and replace it by fibrous tissue. If fibrous tissue is done, then bone will start to form. Now, at the end here, you get a tissue which is made of blood vessels, inflammatory exudate, and when I say exudate, I mean cells and fluid, and this reactive bone. What is the name given to this? انتم من دراستكم السابقة when we studied inflammation, we said we have the ultimate end of inflammation is to make a granulation tissue. if the body form granulation tissue, then from that end it will decide. If there is a treatment, it would heal. If it doesn't, if you don't treat it, it will go into abscess or go fibrosis, etc. But it is granulation tissue. A granulation tissue, in our sense, when we studied inflammation, is made of blood vessels, exudate. Bas. But in here, there is the same component, but there is bone also. ليه اسم؟ What? Come on. Callus. So callus is a special type of granulation tissue. Special type of granulation tissue occurring in fracture repair and contain bone and cartilage, as I mentioned earlier, formed by the proliferation of the osteoprogenitor cells. Osteoprogenitor cells, these are the cells which made the bone, but the inflammatory exudate, the granulation tissue itself made by the trauma. Okay, so you know of any other special type of granulation tissue? I'm sure you know. In this unit we will study several of them. This is one. All right? We will come to and see if there are others. Keep it in mind. All right. The callus can be periosteal, can be endosteal. It depends on where it is, but it is a temporary tissue that required to hold the fracture ends together. Just a temporary one, because that callus would later on form more bone, and for that bone need to be organized. When I say organized, I mean to be mature, to be cortical. This is. I took these pictures from your book. Let me describe them, but they are quite good. You have at one end here a bone, which is this is the cortical bone. هذا الأخضر, these are the osteodilacuni, الحافظة اللي في داخلها الأوستيوسايت. والخطوط هذه بين هذه شو اسمها الموصلة بين دلين. These are the capillary blood vessels. من غيرهم this osteocyte cannot live. All right? And at the end, the fracture end, you find that they are empty because they are dead. All right? So you have a cortical bone, part of it is alive, the other part is dead. This is the bone marrow with fat. This is all the blood clot. Okay? Now, immediately you will have, after the fracture, there will be hemorrhage, which is here. And with hemorrhage, there are proliferation of blood vessels. All of these are the new vascularized blood vessels, as they say. They bring with them fibroblast into the site. But the dead osteocytes are still there, and the live osteocytes are still there. Then you will go into the next phase, which is the reparative phase. And this reparative phase, the external, which is the periosteal, and the internal, which is the endosteum. The endosteum, this is the internal. If you have if you have a bone, if you cut the bone, inside it is the medullary cavity, and outside it is the cortical bone. Right? So if the external callus, this is the one that would form outside, nearer to the periosteum, right? But the internal will form inside. So you have a wall, you have one fold of a callus here and one fold of the callus here, just to hold it. So you have these the external and periosteal callus invade into the fracture side. The osteoclasts themselves, coming from the monocyte, will start proliferating. They have the capacity to eat up and make holes into the dead bone. هاي المشرشر اللي في الأخير. at the ends. To remove it, the debris of dead bone must be removed. This is the function of the osteoclast. Osteoclast cannot function, like any cell, cannot function without blood. So they pull with them wire, they pull with them a capillary. الخطوط اللي رويتكم إياها هناك. So you have the capillaries and you have the osteoclast. تحفر. This is the so-called cutting cones. Right? مثل الحفارة. الحفارة مالت الأنفاق. So الحفارة تمشي تحفر في النفق بس تسحب وياها الوايرات مالت الكهرباء or الغاز whatever it may be. Okay? So in that sense. Once this is made, then osteoblast from the osteoprogenitor cell will start coming in, laying out bone. But this bone is a woven bone, is not a strong bone. It is temporary to hold the bone. We transformed, now the body transformed the fracture site from a hemorrhage and clot into a fibrous tissue into a callus. Now the next stage is to have that repaired, remodeled. Sorry, of course, once you get into this stage, there is no need for the inflammatory response, so it will be gradually stopped. Now, there is this stage of remodeling. What is remodeling? Remodeling له يسمونه بالجماعة اللي يبنون التشطيب. تبني جدار أو أرضية بس مو سيدة مو عدلة. You need تعدله يعني. You need to make it to straighten, to put a tile on it or to put a carpet on it. This is the remodeling. You want to reshape it. So you want to reshape the bone into the original structure, smoothness and integrity. Right? How the body is doing that? It changes the layers of the woven bone, the reactive bone, from a haphazard one to gradual lamellae, طبقات, until it's straight and becomes strong. I still have a few minutes. تصبروا علي بس. أنا عارف اليوم الخميس. This is again the same picture from that famous book. You have both ends now of the cortical bone with the live osteocytes here. These osteoclasts, هذا لأن فيها more than osteoclast contain more than one nucleus. If it is one and just came out from the blood vessels, there will be one nucleus. But I mentioned to you earlier, they are not capable of division, but they are capable of a fusion, right? So they fuse with each other. That's why they have multiple nuclei. يقدرون يصلحون. They eat up هذا الخط المشرشر هذا مالت الcartilage. They lay up their field for all of this reactive bone to form under the periosteum and the endosteum. Once this is done, the blood vessels proliferate further, the cutting cones come and remove all the debris. At the remodeling, you can see that the trabeculae are laid perpendicular to build up the contour, the shape, strength, integrity of the bone itself. These are special considerations that I would like that you take note of. جماعة مال الorthopedic probably they tell you something else or additional, but take up the rib, for example. Reorganization of healed fracture of the cartilage may look like as it is healed, but it is not truly healed because of the shear movement I mean, there is a fracture of the rib. Both ends are near each other. They form cartilage, أكثر منه هو bone, but it doesn't heal because of the movement. This is one of the factors that would interfere with this is one of the modifying factors, right? So it makes, it doesn't heal well. So it remains for a long time until death. There are reports of examining cadavers from تاريخ القدماء المصريين لما يكتشفوا القبور مالهم ياخذوهم بالاكس راي يشوفوا ان بعضهم عندهم fractured rib which has not healed. This is the reason why, because of the shear movement of the rib. The other is that the location of the fracture. If the fracture is near the epiphyseal cartilage plate اللي يسمونه growth plate, this is the cartilage area in the bone which gives the bone its length. Right? It is the epiphyseal cartilage plate. There are two in each long bone, and some bones like in the femur في ثلاثة أكثر من واحد, because that is the area where not only gives the bone its length but its shape also. So fracture at that end near the epiphyseal cartilage plate in children, it will overtake the healing. يعني these stages, the inflammatory, reparative, will be overtaken by the growth of bone. You cannot distinguish with them. Even if you have an angulation, if you have an angulation like this, and this angulation is near the epiphyseal cartilage plate, the growth of the plate will also overtake the growth. The third consideration here I wanted to mention is that if there is an angulation like this, what would happen is that bone will form at the concave, right? And less bone formed at the convex. In fact, there will be more of osteoclast on the one side and more of bone on the inside. This is the remodeling in order to strengthen it. العملية كلها biomechanics. This is primary healing. That is the secondary healing. Primary healing, these are the examples that you will find in books. If you drill a hole in the bone for various therapeutic management reasons, if you do osteotomy, you cut a wedge in the bone in order that you correct the angulation, you correct the stress from one side, like the patient who have osteoarthritis of the knee. Or if there is an internal fixation, there is a fracture, you intend you cannot put the splint on it, so you open it and put a screw. That screw, you bring both ends together. This is it healed by primary intention and not by secondary intention. And the difference is here is that in primary intention there is no displacement. All right, there is the bone ends, both bone ends are together. In fact, there is no cut. There is only a hole, all right, or a wedge, which is a clean cut. Clean, it's will be made by surgery. No soft tissue, no external callus, because bone can grow directly. There is no dead bone. The osteoblast can directly grow. The osteoblast, the osteoprogenitor cell, can grow directly from one end to the other with no need to make a lamellar bone. That would be enough. There is March. Oh, I still have time. إلى الحين 7 دقائق. March fracture. This has been observed in joggers. Joggers, skiers, الجماعة مال الباليه. You find it عندهم هذا stress fracture because they put so much of pressure on certain parts of the bone. يعني الجوجرز والskiers والجنود في تدريبهم part of it is to jog, part of it is يمشون في استعراضات. alright, so إذا يمشي في استعراضات they try to put more علشان يمشي سيدة لا they put more pressure on their tarsal bones في leg rather than any other bone. يبغى يمشي سيدة ذات لما عندهم حركات مالتهم الآن. okay, yes. الجوجرز what they do is that when they jog في الصحراء أو في الغابة أو في الجبل يمشي على أو يركض على سطح مو مستقر كله حصى وتراب والى آخره. فلذلك they think of how to cut that distance. يوم يبغي يركض بس يبغي يحافظ على نفسه انه ما يطيح. in this way they put so much pressure on the big toe علشان يحفظ اتزانه. but the pressure in fact is falling on the tarsal bones. right, so with time this fracture started, it's a micro fracture. كل مرة يركض there are several micro fracture, but the body started to repair them by forming callus. Callus at the same time the body also want to make remodeling. so العمليات مالت البون مالت الهيلينج كلها متلخبطة because there is a repeated trauma on it until such a time when the body cannot cope anymore, so there is a real fracture. This is the stress. So it occurs in ill-prepared bones containing less osteones like the tarsal. And I mentioned here there was a number 5 here, fifth metatarsal, but I removed it yesterday. فغيروهم رجاء I gave you this last week. كان فيها number 5, remove number 5. It's all metatarsal and joggers, skiers, ballet dancers the same لأنهم أيضا يوقفون على أصبع واحدة ويلفون لا. But there is more of a pressure on their tarsal bones. Okay, this is healing of stress fracture. You can read it also. This is quite well informed information. The late fracture, late complication, delayed union or non-union. This is the one which never heal. Malunion, it heal but with angulation or not properly. Pseudoarthrosis. Pseudoarthrosis, this is when both ends of the bone are not near each other, but the soft tissue in between, which is also full of pluripotential cells, started to make cells يسموهم indistinguishable. يعني لا يمكن التفريق فيما بينهم وبين السينوفيال tissue. It makes joint, which is a pseudo joint, joint كاذب. There are also many other deformities and other late complications. These are the factors that would interfere with cell renewal and healing. I will repeat this again when we talk about wound healing, but I will leave it for you to read. You want to ask me any question before you sleep? Are you sleeping? All right, Shabab? No? Anyway, I will still be with you next week, inshallah. Again, I will encourage you, if you need me, عندنا سكرتيرتنا في الدور الثالث اسمها حصة. You can book an appointment with her and I'll be pleased to meet with you. All the best. كل عام وانتم بخير.